So in session 1, we've obviously focused a lot on the starting fast with hands-on and rehab. In order for them to come back to the second session, we need to be able to prescribe the right rehab exercises to keep the gains from session 1 so that we don't have that loss of motivation or certainty. And that's really about prescribing the right rehab exercises in the patient's environment.
So today is going to be all about exercise prescription and exercise selection, how to coach certain exercises with patients. Now, what we're going to get them to do this morning is we give them a little bit of a task. We've given them a load of outcomes that a lot of patients typically struggle with. We're going to get them to use the Go-To Clinic Hub and go into the how-to library and almost try and figure out what exercises they might give for a certain problem. And then there's going to be a little bit of a section more on specific muscles. So you find a certain assessment that's positive. What exercise could you give for that specific muscle? So they're going to be using a lot of the Clinic Hub today, a lot of the how-to library and the exercise library to try and figure that out. And then we'll kind of come together and kind of give a little bit of a summary from last week's stuff that they went through. And then we'll go through that task together, speak about what type of exercise we could give, and then really specifically work on what we're cueing and what we're coaching for that patient to make sure that exercise is the right one for them.
Today, the therapists have come back from week 1. They've obviously consolidated a lot in terms of the first week was all about stage 1, mapping treatment plans, getting the buy-in. Stage 2 was all about starting fast to make sure that the patient felt the difference, and then prescribing the right fast start rehab exercises in the first session so the patient could feel the difference and rebook and turn up to the second session, which was stage 3 of the patient journey.
It's really really want a lot more medial hamstrings. We'll be getting a lot of medial hamstring care.
Formal grip still.
Right. I have got a film on myself.
You can tell like a massive difference from us last week, but because there has been a week in between, it's like kind of like trying to remember what we learned and then bringing it all together at the end. So like we've just gone over the stuff that we did last week, and like it's made so much more sense now that we know other stuff. But we had to like proper re-jog our memory.
It's because we've not done a third off a phone roll. Because I just went with the slouch. But your hips were going out. Yeah. I think so. I don't know.
Teach me how to do it.
So like you're leaning all these body weights and these hips.
Also, you got abs and half. So just do it.
It's to, no,
You do it.
it's so that like when you lean, it like shifts your body weight to that side.
System. So full disclaimer, if this is a bog standard acute non-specific low back pain patient, first time
advantage of actually getting nasal breathing.
We went through quite a lot last week, so just jogging his memory on that when watching some of the videos this morning, and then we went into more of the sort of rehab and the exercise program this afternoon. So it's a lot, but it's gone well, I think.
Oh. No, but you're coming off really high. Like, even then, you probably still drop lower. Knee up. When your hand against your knee, so the internal release, you push your knee into your hand while there's a balloon in. I assume it's going to be the balloon was nice. But then for external obliques, you push your hand onto your knee. Can you feel the difference? Can you?
The last few days we've gone through obviously the working hypothesis, so be able to map out a patient's story and understand what you think is the problem. The objective assessment and the hands-on kind of teach and solidify what your hypothesis is going to be, so it kind of gives you a bit of confirmation on that. And now this side of the onboarding is going to be, okay, you understand what you think the problem is, but what rehab are you going to give to make sure that they progress between this week and next week? So it's going to be in a really important stage, because a lot of therapists do really well in the initial assessment because there's loads and loads of structure to follow, but then you kind of get into your follow-ups and you kind of lose track of where you need to progress certain rehab and things like that. So that's going to be the focus for this week, is make sure that we can get the right exercise selection, what the progressions, what the regressions are going to be for certain problems. And from a head physio perspective, that's really important, because I want to make sure that all of their patients they're treating, they're moving nicely across that graded exposure and they're progressing week by week and they're not stalling. And that a lot of the time comes down to their exercise selection. So Hopefully it's going to teach them the important skills of refining what exercise to give. Don't overcomplicate things, keep it simple, but there should be a natural progression each time that they're seeing a patient. So you always want to be thinking shortening and lengthening, because that's what will tell you a specific pathology in the first place. That's what's leading you to an ACL, is that specific mechanism. Okay. So shortening and lengthening. What about gradual? What are you thinking with those?
What were you doing when you first felt it?
Yeah, so I guess what was the difference in your routine leading up to it is probably the thing. But yeah, you're right. So what were you doing when you first felt it? What would you do exercise-wise for someone that's going to fight or flight?
Breathing.
Yeah, like loads of breath work stuff. So I'd say that's almost like your breath work, and then just loads of strategies in terms of how to do, like how to manage the symptoms. Because if they're saying, I'm getting it whenever I see my boss, that's when my back's really, really bad, your breath work is only really going to come in when you're seeing your boss. You almost give them the strategy to manage the symptom. Okay? I just want to really drill this into you, because the more you think about it like this, the easier you'll find it all. So what's the skill needed for you to reach across going this way? How do you progress? Let's just say you've done slouch, you've done foam roller bridge single leg. How would you get into the next level?
You did RDLs towards thumbs.
Yeah, RDLs would be like towards that stage, that's fine. What's the dynamic way to bias the hamstring? So pop your right midfoot in contact with the towel. Should probably go a little bit further back. Perfect. And then just Hannah, coach for a slouch for me.
Slide down knee.
We put some exercises together, but we didn't go fully through them. So then when Ollie was there, like he went through them with us and then made us kind of redo it back. So then it got into your head a bit more, but we still weren't properly like confident in it. But by the end, I was a lot more confident because we'd done it a few times.
I know the top of his midfoot. So I would say if you stand nice and tall, okay, go on your split stance for me. Just go as far forward as you can with your whole body weight. Okay, see how you feel a bit trembly? Yeah. That's your starting position. Okay. If I want to get more soleus, what do I get him to do now? Yeah, lift your heel just half an inch. Good. Nice. Tiptoes on your back foot. Don't want any weight through your left foot. And now you just do the exact same exercise. So see how you're shaking up more now? Yeah. Okay. And so the key thing I would get Alex to do that again for me, Alex, to give you a prime example of something that just cheat it on the way up. So keep your weight forward now as you come all the way back up. Don't let your weight go backwards. That's it, good. And then you go all the way back down again. So all the way down. That's it, good. So that I don't mind, because that just means it's hard enough for you. Okay. You don't want that to be easy for someone. So you don't want to just be going up and down and feel a stretch for your hamstring. You want to feel your calf, your glute working quite hard.
I'm sort of a bit taken aback at how much there is. But that's a good thing, because obviously the more there is, the better physio you're going to be.
Yeah, so the patient needs to understand the why behind everything they're doing, and the word for that is context. The patient needs to do an exercise, but if the patient doesn't understand the why behind the exercise, then that perceived value of the exercise essentially is meaningless. So essentially what we do here with the exercise is we need to frame the exercise, and we need to frame the exercise in a way that increases the perceived value of the exercise. So if I say to you, I want you to do this knee strengthening exercise, then there's a chance that you will do it. If I say to you, okay, this exercise is going to help you hit that PB, beat all your mates in the 10K when you get back, and get that medal around your neck, then straight away what I've done is I've increased the perceived value of the exercise.
I'll keep your hips sort of locked in, then pressure on that other foot, then back over and keep your hips forward.
Yeah, better. There you go. Do 4 reps of that.
Yeah, just like a count.
It's not hard at all.
Anything that drives you forward again. Okay, so that's a really important exercise to get really comfortable with.
Is it through the midfoot?
Probably go for his heel on the way down. Okay, because you think about, if I keep my weight from my midfoot, I'm going to be going like that, and put a load of pressure for his knee. Okay, so you probably want it for his heel, but his knee's still going forward. Okay, so what I tell you to do, just keep that into my hand all the way up and push your hip through. Keep pushing. So that's way better.
Okay, taking a step.
Yeah, exactly. So like that's a cue you can give, isn't it? Out, 4, 3, 2, 1. So you definitely can hold it for a period of time. Just the initial forward is not very good. So if someone says, I can't do that, just try doing a short burst first. It's getting loads of pain with like deep squatting. Your adductors is going to be really important. Okay. The typical one for men is they don't use the adductor machine in the gym, so they think it's a female machine where your right leg.
What do you mean to
Lift up in the air. Yeah, you can do that.
that?
Yeah, there you go. So that would be an exercise you could give for high tension adductor, isn't it? Okay, because you're going to be doing that type of movement very, very aggressively. That's what's keeping you stable, which is going to get loads through your adductors. Make sense?
Yeah.
You can't make that easier, Hannah. How would I make that easier for you?
Lower. That one.
No, not necessarily lower. That's quite a long lever, so that's hard for you. How could I make that shorter lever?
Prescribing the right rehab exercise at the right time, it's a little bit like Goldilocks, and very often it's not the exercise that can be the problem, it's just the timing. And the biggest issue we have as private practice therapists is we're not dealing with a muscle, we're dealing with a nervous system that governs that muscle. So as I said, if we load a tissue too early and there's an increased threat response, then usually what tends to happen is the nervous system tightens up or it can increase the pain. So really it's about having that test, intervene, retest approach, and that gives us a lot of confidence that, okay, we're going to test something, we've got a working hypothesis, we're going to give the tissue a stimulus, and then we're going to retest again. And that key performance indicator, or KPI, should be improving after the stimulus. So the inputs lead to the output is the KPI, and then that improves. If the KPI isn't improving, then that's a sign for us that stimulus is maybe not the right stimulus at this right time. So that's where then we would regress on the graded exposure ladder. So again, it really shows the value of having a step-by-step system for Hannah and Alex to organize their thinking and know exactly where they are. So if this stimulus doesn't give the required improvement, then that's fine. We don't panic. We can just regress and give the patient the right stimulus at the appropriate graded exposure level.
I to almost go like right up. So almost you want to imagine you zip this point towards 10 o'clock.
So like that.
Yeah, that's better. And then all the way back down. Good.
So I can't help but do this.
Slow it down. That's it. Push through your knee and all the way up. That's better. Good. Nice and slow all the way back down. Keep that into my hand. That's it. Drive all the way back up. Good. Better. All the way down. Keep that into my hand. For sure. It'll be a big one because if I drop this down, he's probably going to drop down like that as well. So if he keeps that high, but he's just thinking about his hips dropping down, it's probably going to stop loads from there.
Yeah.
Okay, so keep that leg the same height from the Alex and just go up and down from there. So now that's going to be a lot more for his hips and less so for his back.
Yeah.
Okay. I reckon you get higher range.
Confidence, I think, stems from the fact that it's me, Ollie and Hannah, and obviously they're easy to talk to. Like if you do something not I forgot the word wrong, then if you do something wrong, then Ollie's sort of there just to kind of help you out. Confidence wise, I don't think it's massively a problem in situations like that, but it's just us three. Just because, like I said, if you say something wrong or you go back in the wrong way, Ollie's there to kind of guide you through it.
The oblique is just the knee past 90 and then pulling across, pulling across that way. Okay, so that's the internal external oblique. Internal oblique. It's more, you want to imagine you're fogging up a glass, you're in mouth nice and wide and go like that. And that's going to get loads of retraction.
Yeah, it's really important to tick off these early stage goals and know we're winning, not just for the patient, but also for the therapist, to give them confidence that they're on the right track. And again, it's the equivalent of playing a game and not knowing the score or not knowing if you're doing well. And again, understanding and really tracking the milestones in the first 3 sessions allows us to see if we're winning or losing. And if we haven't hit those first 3 milestones, then that's the equivalent to losing. So we have to make a substitution in terms of the treatment techniques, or we need to change the strategy. We need to work smarter, not harder, essentially. So it's absolutely critical that we hit those milestones to reinforce confidence, not only in the patient, but also in the therapist.
How would you then bias his external oblique?
Those glutes.
Yeah, so bend your knees, Alex. Get into a nice relaxed position. Okay, so then go through it.
Take a deep breath in through your nose. And then we purse lips. Breathe out, breathe out. And then just.
Fine, so slow breath in. Exhale for as long as you physically can, Alex. Keep going all the way up. Be quite forceful with the exhale. So keep going, reach your hands up. Keep going. If they stop halfway through the breath, they're not getting a good contraction. Okay, so you want to get them to fully mobilize their ribs. So blow out for as long as you physically can.
Yeah, so now this week, the therapists they've done a really, really good job of prescribing the right rehab at the right time. And a lot of the rehab exercises was focused on bridging that gap from transactional rehab to transformational rehab. What they're going to be doing next week now, they're going to start to get some patient exposure, but they're also going to start looking at bridging the gap from low to high level rehab. And that's really stages 5 of the patient journey, when pain is eased, but there's more progress to be made. And then getting the patient to stage 6, which is making sure that they have moved from fair full to fairless, and they've got that physiological but also psychological transformation. So that's always the testing times with therapists. So they'll go in now, they'll watch the relevant modules in the Go-To Therapist Mentorship this week, they'll use the Go-To Clinic Hub, that'll do 80% of the lifting for us, and then when we see them next week, then they're ready to hit the ground running, and we can inspect what we're expecting.
Today's all finished, which is great. They've done really, really well. So they've covered a lot of content today. There's a lot of protocols or a lot of outcomes that we went in to get through. All the really common ones for a lot of different problems, like your lower backs, hips, knees, shoulders, whatever the problem is. They've done really well. I think their exercise selection was fantastic. And they just need a couple of tweaks in terms of their cueing and the coaching, but that's perfectly normal at this stage. They've not ever seen these exercises before, so it's quite normal. So they did really, really well, and hopefully they've seen that there's quite a common theme that we use a lot within the mentorship anyway in terms of the rehab. The progressions are all quite similar, and you can really see now that their confidence is building and building now. So we did a nice bit of summary bit at the beginning where I was kind of just going through pretty much everything they covered all of last week. So we went through the subjective questions, went through what the 4 ProSport questions are, what the process is for your hands-on techniques, and they remembered that stuff really, really well. So they can see now the confidence is building a little bit more. And then we'll see what it's like when we put it all together in the coming days. So tomorrow is going to be the focus is actually going to be tying it all together now. So I've given them 2 new case studies for them to work on for tomorrow. They're going to brainstorm all of that. So think about the story or the questions they're going to need to ask to make sure they're really happy with their hypothesis. Map out the patient V, get a good understanding of what they want to do rehab-wise, assessment-wise, hands-on-wise. And then we're actually going to run a mock initial assessment. So I'm going to pretend to be the patient and then see how they get on with that and see how they tie everything together.
Yeah, good. Firm but fair? Yeah, good. Go on.
Silence.
Just make it easy for yourself. Let's go same position. So kind of try and almost bring your little finger up towards you. So that's always going to be supination, and then do the opposite way, so go from that way. So that's probably the better handling you can do, because you can
get back to the gym from here, but I wouldn't recommend it if you're paying them to come back. Do you understand what I'm saying?
So that would be more his proximal hamstring going into his hip.
Yeah.
So a bit of proximal gastroc. It will be the whole of his hamstring, but mainly sense lotus proximal.
So then when it's toes down, is that mainly distal hamstring?
Yeah, exactly. Yeah.
Right.
So